Tokyolive Endoscopy 1.
Good evening, everybody. It's my pleasure to co-chair this seminar organized by Olympus during Tokyolive, the famous Tokyolive course. And I have a pleasure to co-chair with Professor Nagi Reddy from India. Of course, Nagi does not need any introduction. He's a fantastic endoscopist from Hyderabad. This seminar is dedicated to a new technology provided to us by Olympus, and I want to really thank Olympus to organize this seminar, which is focused on two new functions, TXCI and RDI. So I'm personally very interested to know the clinical advantage of these two new functions. So the first presenter will be my friend and colleague, Dr. Seijiro Abe. He is from National Cancer Center from Tokyo, but he has been trained initially in Sapporo. And of course, Sapporo is well known in France, at least for Olympic Games, for example. It's a fantastic place. And Seijiro is working now at the National Cancer Center, such as I already explained. And he's, of course, a famous endoscopist in the world of diagnosis and also therapeutic endoscopy. I know Seijiro because he's an excellent, fantastic reviewer. Of course, he had many, many publications, but he's well known for excellent reviews he has done, and he received many, many awards in the world for all these reviews. And is, for example, working for GI endoscopy, and is member of the board of GI endoscopy, member of the board of endoscopy. And I had the pleasure personally to ask him to become co-editor of the journal I'm in charge, Endoscopy International Open. So he's a great reviewer, but of course, to be a great reviewer, you need to be a great expert, and you need to be also a great expert to evaluate new technologies such as the one provided by Olympus. So, Seijiro, it's my pleasure to ask you to speak about the future of screening upper GI endoscopy with TXCI.
Thank you so much, Professor Ponson. Good afternoon and good morning. It is my great pleasure and honor to be able to talk to you in this session. And thank you so much, Olympus, for your kind support and having me. Let's get my presentation started. My topic today is the future of screening upper GI endoscopy. Here you can see the incidence and mortality of gastric cancer in Asia. Blue bar indicates the incidence, red bar mortality. The gastric cancer mortality rate in Asia is 75%. However, it is much lower in Korea and Japan. In these two countries, screening EZD is commonly performed, and which contribute to early detection and the reduction of gastric cancer mortality. In Japan, screening EZD is performed according to a systematic screening protocol proposed by Professor Yao. As shown in this slide, quadrant images were taken in the antrum and lower gastric body, and then endoscopic images were systematically taken in retrofraction as well to inspect the entire stomach. However, some early gastric cancers can be missed during screening endoscopy, particularly a small and flat early gastric cancer. The false negative rate, so-called early gastric cancer miss rate, was reported to be 4 to 26%. These slides show the early gastric cancers with subtle color and surface change. Hope you can identify it. Previously, the second generation narrowband imaging and NBI were supported to be effective to identify early gastric cancer. It is challenging to identify slightly reddish shadow-depressed lesion in white-red endoscopy. However, it could be visualized as a blemish area in NBI. A multicenter randomized controlled trial was conducted to investigate whether or not the second-generation NBI can improve the early gastric cancer detection. Patients were randomly assigned to primary white-red imaging followed by secondary NBI, and primary NBI followed by secondary white-red endoscopy. The primary endpoint was real-time gastric cancer detection rate. Actually, there was no significant difference in gastric cancer detection rate between the two groups, although the positive predictive value was significantly higher in the NBI group. A further development of image-enhanced endoscopy has been warranted to improve the quality of screening endoscopy. Based on the background, last year, Olympus launched the new image processor, EBIS X1. The color CCD-based EBIS X3 and monoclonal image-based Lucera Elite has been merged into the new combined EBIS X1 processors. Both 190 and 290 scope can be directly connected to the EBIS X1 CB1500, which combined the two previously separated worlds. Currently, we can use a brand new high-definition gastroscope XC1200, which is a successor of H290Z. This endoscope uses a high-sensitivity image sensor, which provides HQ image quality and high-speed sequential imaging to minimize rainbow artifact. Of course, we can also perform the magnifying endoscopy up to 125 magnification level. Here you can see the images of the same early gastric cancer in H290Z and XC1200. The image quality of the white-red endoscopy is improved, as you can see. The mucosal pattern and the vessel pattern are obviously more clearly visualized in XC1200 than in H290Z, whichever used in our clinical practice. Furthermore, this EBIS X1 integrates the new image-enhanced endoscopy, texture and color enhanced imaging, TXI. TXI aims to enhance the visibility of suspicious area during a lesion detection, enhancing the subtle surface elevation and depression, brightening the dark area with a light reflection, and subtle color change. In TXI, input imaging is split, and texture and brightness were enhanced, and both images were merged. And color enhancement, particularly between the red and white, are made to more clearly define the subtle tissue difference. This is TXI mode 1. TXI mode 2 consists of the texture and brightness enhancements without color enhancement, which allows you to use it like a standard white-red endoscopy. Here you can see an early gastric cancer. The mucosal pattern and the image lesion margin were more clearly identified by TXI mode 2 here. Moreover, the reddish color is enhanced in TXI mode 1. And furthermore, the proximal side of the stomach is more brightened in the TXI compared with white-red endoscopy. Honestly, in this case, an early gastric cancer was incidentally found during preoperative endoscopy for an esophageal cancer. A slightly pale vacuum mucosa was identified on the anterior wall of the lower gastric body. And getting closer, this region can be identified as a slight vacuum mucosa. After changing to TXI mode 2, this region can be identified as shallow depression. And furthermore, in TXI mode 1, the pale color was identified. Allow me to introduce our pilot study to investigate the color difference and the visibility of the early gastric cancer in TXI, which presented at the JGS Congress and DDW this year. In this study, we created 3 EGC images of white red imaging, TXI mode 1 and TXI mode 2 from a raw image dataset of the Lucena elite using a computer simulation. These 3 images have uniform distance, angle, and air insufflation. We evaluated visibility of early gastric cancer with TXI, and 4 endoscopists, 2 experts and 2 trainees, independently and randomly reviewed the image dataset consisting of the 20 pairs of white red imaging and TXI mode 1 and 20 pairs of the white red imaging and TXI mode 2. They scored the visibility of TXI mode 1 and versus white red imaging and TXI mode 2 versus white red imaging. They score the visibility according to the visibility score reported by Imagawa et al. And improved visibility was defined as a total visibility score of 5 points or more. The mean total visibility score of TXI mode 1 as 3.4, and visibility was improved in 35% of lesions. The mean total visibility score of TXI mode 2 was 3.0, and the visibility was improved in 20% of early gastric cancers. The lesion characteristics with improved visibility in TXI mode 1. Despite the limited sample size, the EGC visibility was more likely to be improved in pale early gastric cancer type 02C or 2B in macroscopic type. This is a representative lesion which are better visualized in TXI mode 1. In white red endoscopy, a slightly pale vacuum mucosa seen in the greater curvature of the lower gastric body. It is a little bit challenging to identify the lesion in white red endoscopy. If we look at the TXI mode 1, you can see the shallow depressed lesion with pale color. I'd like to say that the quality of the NBI images is also improved in EBIS-X1. In some cases, the lesion is better identified in NBI rather than TXI. The small type 02C early gastric cancer was identified as a brownish area in this case. And the further evaluation is warranted between the TXI and the NBI. Moreover, the image quality of the magnifying NBI is excellent. In this case, magnifying endoscopy with NBI demonstrates the irregularly branched microvessel and microsurface pattern with a demarcation line. Definitely, we can diagnose it as an early gastric cancer. NBI is very helpful to identify the esophageal squamous cell carcinoma, as you can see, particularly the flat and small esophageal SCC. The lesion is normally identified as a brownish area in NBI. Here you can see the very famous randomized controlled trial by Muto et al. This study compares the real-time diagnostic yield of superficial esophageal cancer between conventional wide rate endoscopy and narrowband imaging in high-risk patients. As a result, NBI detected the superficial cancer more frequently than did wide rate endoscopy in the esophagus. Based on the result, an NBI is recommended to use as a standard modality to detect the esophageal SCC. Of course, this rationale can be adapted to a new NBI in EBIS X1. In addition to TXM Mode 1 and Mode 2, EBIS X1 has another enhancement mode named BIMAC. BIMAC is an abbreviation of the brightness adjustment imaging with maintenance of contrast. BIMAC improves the brightness in the darker portion of the endoscopic image. It can be utilized to non-magnify NBI observation of the esophagus. When we use TXI for esophageal squamous cell carcinoma, the color and depression are enhanced as expected. And if we change to NBI, then obviously an NBI is the best available image enhanced endoscopy to enhance the lesion. And furthermore, the BIMAC can brighten the darker area as the distal side where the illumination cannot reach. I believe it can overcome the limitation of the current NBI. Of course, the image quality of the magnifying endoscopy is excellent. You can see the clear irregular vessel with loop-like structure, which allows us to diagnose superficial esophageal SCC with the deepest invasion to lamina propria mucosa. Actually, this lesion was treated by extensive ESD. Somebody noticed that iris mode can also brighten the endoscopy field. That's true, I agree. We normally use an auto mode for therapeutic endoscopy of EMR and ESD. However, if we look at the auto mode image, it brightens only the proximal side and near side of the esophagus, and light reflection is concerned. On the other hand, BIMAC allows us to illuminate the darker area at the far side and distal side of the esophagus. This is the advantage of the BIMAC. In my opinion, the BIMAC can also be utilized for future AI endoscopy, creating the better test set imaging in the esophagus. Lastly, let me quickly comment on the structure contrast in wide rate endoscopy. Olympus processors have two modes: an A mode, which makes the vessel and the mucosal pattern thicker, and B mode, which makes an edge of the vessel and clipped pattern sharper. Despite the very slight difference among A6, B6, and B8, I personally prefer the structure contrast B6. I asked my colleagues, and they all agree with my setting. Here you can see my EBIS X1 setting. I use XC1200 for screening and diagnostic EZD for esophagus, stomach, and duodenum. I would prefer the structural enhancement of B6 with peak iris mode. When it comes to image enhanced endoscopy, I think the TXI mode 1 is superior to mode 2. In terms of the NBI, definitely the structural enhancement B8 is the best to evaluate microsurface and microvessel patterns. In summary, EBIS X1 is a new processor that provides clearer and higher resolution images than before, which may improve the quality of the screening upper GI endoscopy. I believe that endoscopists all over the world can use universal endoscopy system and have discussion and develop collaboration with the same high quality image in future. TXI, and particularly TXI Mode 1, can enhance the structure and color difference, thereby improving cancer visibility compared with white-light endoscopy. And BIMAC can illuminate the distal esophagus. The new image-enhanced endoscopy may also be utilized for future AI-assisted endoscopy. This is my personal opinion. Finally, not just the least, so far, little is known about the clinical impact of the new image processor. Thus, the large-scale clinical trials are warranted to investigate the performance of EBIS X1 for real-time cancer detection. Thank you so much for your kind attention.
I want to thank you, Dr. Abe, for this excellent presentation. And a great technology such as EBIS X1, of course, requires a great presentation, and you did perfectly. First, you were very clear concerning the technology, and your image were impressive, and at the end, your settings were probably very helpful for a lot of customers, a lot of doctors around the world. I want to focus on TXI, of course. Despite I was impressed by magnification, I was impressed by BIMAC, especially in the esophagus, I must say. But concerning RDI, we have NBI, and we have white light in the stomach. And you are speaking about visibility. What do you mean by visibility? Is it detection or is it characterization?
Thank you so much. I think so. A TXI is basically designed for cancer detection rather than characterization. So I think the TXI is a promising modality to maybe increase the cancer detection rate. But maybe the TXI can also be helpful to improve the region characterization, because the irregular margin and irregular mucosal pattern can also be enhanced by TXI. But there is no data about that. So I think the further study is warranted to answer your question.
Okay. So yes, because for us, detection, of course, very important, because as you know, we don't have so many cases, so we need really help for detection. In comparison to Japan, you are much better than us. Now I will let the floor to Nagi, probably has also a question to Dr. Abe.
No, I think, thank you, Dr. Abe, for that excellent talk. And as Terry rightly commented, I think you demonstrated very well the new technology. It's used specifically in situations where it can complement NBI. Thank you very much.
Thank you.
Yes, but maybe Nagi, you are not interested by the esophagus, because maybe if I can ask the last question, do you think that BIMAC, I was impressed, could be a standard, and when could become a standard?
Yes, I think so. There is no disadvantage of the BIMAC. So nowadays, I normally use a BIMAC for esophagus, almost all cases.
Yes, because the image were great and fantastic.
Yes.
You see at a distance, and this is frequently the problem. We are focused very at the close distance, and we don't see at a distance. It is always a problem. Thank you very much, Dr. Abe. Nagi.
Thank you, Terry. I think it's a pleasure to be a part of this Olympus Evening Symposium on Tokyolive, and also honor to be a co-chair with Professor Terry Ponshin. Our next speaker is Professor Toshio Hirooka. He is a professor of gastroenterology and hepatology at the Guma University Graduate School of Medicine in Guma in Japan. Professor Hirooka has got several publications to his name. His field of interest is mainly diagnostic therapeutic endoscopy for early stage gastrointestinal tumors, as everybody else in Japan. He's got not only a huge number of publications, but 9 patents he's got. He's an editorial member for the Den Open and also for the Canadian Journal of Gastroenterology and Hepatology and for the World Journal of Gastrointestinal Endoscopy. Dr. Murioka is going to talk to us mainly on the new function, what we see in EVS X1 regarding the RDI, where you can see the deeper vessels much better. Professor Murioka, we are waiting to hear you.
Thank you very much for kind introduction, Professor Lady. Good evening and good morning, everyone. Please start my presentation slide.
Good evening and good morning, everyone. I would like to thank Professor Inoue and Olympus for inviting me to speak to you today. The latest endoscopy system, EVS X1, has been launched in Europe and Japan last year. Red dichromatic imaging, RDI, has been installed in EVS X1 as an advanced optical digital method originally developed by Olympus as well as TXI. Today, I'm going to talk about the usefulness of this novel advanced image RDI from Olympus for about 20 minutes. Now, let me begin. Regarding my COI, I have no disclosure and financial support. First of all, I'll talk about the wavelength characteristics of illumination light in NBI and RDI systems. In NBI, shorter wavelength lights of blue light and green light are used. NBI emphasizes the surface and the vessel patterns on the mucous surface, and this technology has been widely used for endoscopic diagnosis in the gastrointestinal tract. RDI utilizes longer wavelength light, green light 540 nanometer, amber light 600 nanometer, and red light 630 nanometer, having weak light scattering characteristics with the reverse thinking idea of NBI has been developed. RDI can be switched instantly from white line image by pressing the single button on the endoscope as well as NBI. Based on the principle of RDI, we hypothesize that this novel technology has two advantages. First, which enhance the visibility of a thick blood vessel in deep tissue and bring the point with see-through effect and color contrast. We can be a whole new world by using RDI. Now, I'll explain those advantages and clinical impact of RDI in order. NBI has been developed by an Olympus engineer, Mr. Gono, and being commercially available in 2007. This imaging was a revolutionary invention, and he became an absolute legend. The first in-human feasibility study of RDI was approved in 2011 under the name of dual-red imaging RDI based on a previous endoscopy system, EVS Lucera Elite. RDI has been mainly developed by Mr. Gono's subordinate, Mr. Igarashi. Professor Yahagi, our colleagues, and I had a lot of discussion about the usefulness of RDI with Mr. Igarashi. I seem to be asleep in this photo, but I was seriously thinking about RDI at this time. Although NBI makes it possible to emphasize the capillary network and the surface structure on the mucosal surface, we could show to emphasize the visibility of deep blood vessel based on the principle of RDI. As an experimental result, it was confirmed that thick blood vessel located 1 to 2 mm in depth, which are difficult to identify by white light image and NBI, can be visualized by RDI. The use of RDI is expected to enhance the visibility of esophageal varices. This video clip shows a lower esophagus after several sessions of endoscopic sclerotherapy. In white light imaging, it is difficult to observe vessels. However, we can see visible vessels after switching to RDR. Based on this finding, additional sclerotherapy was performed. Fukuchi evaluated the ability of a prototype of RDI for esophageal varices using EUS. They revealed that RDI enabled the prediction of the depth of esophageal varices based on their color and thickness and visibility of esophageal varices. Positioned shallowly from the epithelium was more enhanced by RDI. Meanwhile, Professor Nanuma and we suggest that the usefulness of RDI for evaluating the inflammation in ulcerative colitis patients. He established a RDI score based on the visibility of vessel and demonstrated that this score was closely correlated with both the endoscopic and the histological grade. The finding of RDI may be able to change the decision-making of treatment of esophageal varices and ulcerative colitis. Further prospective study were needed to evaluate the enhancement of the visibility of deep blood vessels in esophageal and ulcerative colitis patients. Here is a video clip of urgent upper GI endoscopy. As you can see, there are four ulcers with blood clot and bleed around the ulcer are observed. After switching to RDI, we can see the effect of increasement of the transparency of bleeding area with low blood concentration. You can clearly see the difference between two images. This operator could easily apply the coagulus path to the bleeding point. This slide shows the comparison between RDI and white light imaging. RDI increases the transparency of the area where the blood concentration is low, while enhancing the visibility of bleeding point and thick blood vessels where blood concentration is very high. In addition, we found out the bleeding point and its peripheral area are displayed in different colors based on how much the reflected light intensity of 600 nanometer is attenuated compared to that of 630 nanometer. The special image processing installed in RDI properly adjusts a bleeding point to be represented in orange and its peripheral area in yellow. Tanaka and Kobusa reported the usefulness of RDI for endoscopic hemostasis of gastric and duodenal bleeding in 2017 and last year, respectively. Here is Mr. Igarashi's memo about the prototype of RDI, which is written in Japanese 10 years ago. We have already found out that RDI enhances the visibility of bleeding point during EST with color contrast. The intraoperative bleeding is unavoidable during the mucosa incision and submucosal dissection, and appropriate endoscopic hemostasis using coagulation forceps or the tip of an EST knife is required for bleeding from exposed vessel at the ulcer base or submucosal layer. However, it is sometimes difficult to maintain a clear visualization and identify the breathing point easily and rapidly. We are expecting the usefulness of RDI during ESD procedure. Here is also Mr. Igarashi material, which is partially written in Japanese. The narrowband light of 600 nanometer is strongly absorbed compared to that of 630 nanometer. When this light incident on the bleeding point where blood concentration is very high, the reflected light intensity of 600 nanometer is attenuated dependent on the concentration and volume of blood at a bleeding point. Since both light were less absorbed by hemoglobin in the peripheral area bleeding point where blood concentration is low, these reflected lights are detected with equal higher intensity. Therefore, the bleeding point and its peripheral area are displayed in different colors based on how much the reflected light intensity of 600 nanometer is attenuated compared to that of 630 nanometer. The special image processing installed in RDI properly adjusts a bleeding point to be represented in orange and its peripheral area in yellow. I'll show you the usefulness of RDI during gastric ESD. As you can see, it is difficult to identify the bleeding point with white light imaging, but RDI can easily identify the bleeding point, and we can coagulate the bleeding vessel accurately like this. Next video clip shows intraprocedural bleeding during chronic ESD. At first glimpse, it looks like multiple bleedings have occurred in white light imaging. Upon switching to RDI, we can identify the bleeding vessel clearly. Although there was intestinal wall movement with braces, an appropriate hemostasis was achieved by coil spur. To clarify the management of intraoperative bleeding during ESD using a prototype of RDI. In this study, coagulation using RDI was compared with white light imaging when intraprocedural bleeding occurred. The results were now being analyzed, and I'm looking forward to finding out the outcome of this randomized control trial. This is a case report of a poem using RDI by Professor Lady's team. They describe that RDI clearly shows the vessels in deep mucosa or submucosa compared with white light imaging during poem. The intraoperative bleeding is unavoidable during this procedure, and so we are expecting RDI to be useful for safer and effective procedure. Furthermore, we found out that RDI is useful in maintaining clear visibility. We often encounter an endoscopy lens becoming clouded, especially when dealing with fat tissue in submucous layer. RDI can maintain clear visibility in such circumstance. Compared to white light image, the color contrast between submucous layer and muscle layer can be more enhanced by RDI, as the concentration of indigo carmine in the submucous injection material increases. So RDI is useful for enhancement of submucous layer during procedures of ESD and POEM. In our experience, the higher concentration of indigo carmine improves the identification of submucous layer, resulting in safer submucosal dissection. We recommend using a higher concentration of indigo carmine as a submucous injection solution in ESD or POEM. Based on the clinical benefit of RDI, we propose entire ESD procedure from submucosal injection to mucosal incision and submucosal dissection using RDI, naming full-time RDI. I will present a case of ESD in the lower rectum where RDI was very useful and effective. The other side of the tumor was in contact with the dentate line. The tumor was type 2B of the JNET classification and was 5I mildly irregular of the pit pattern classification. ESD of rectum has a higher risk of intraprocedural bleeding due to the venous flexus. Therefore, we performed the entire ESD procedure using RDI. First, we studied mucosal injection while avoiding the deep vessel using RDI. In RDI, deep vessels look orange. And then mucosal incision was also performed while avoiding the deep vessels. And the peripheral incision was completed without active bleeding. And the bleeding occurred. We identified the bleeding point in RDI and achieved hemostasis. RDI can enhance the contrast between the vessels and the surrounding tissues. Therefore, in RDI, the bleeding point was more distinct than in white line imaging. Submucosal dissection was also performed using RDI. The tumor was resected en bloc without any adverse event. We suggest full-time RDI not only for identifying the bleeding points for quick and effective hemostasis, but also for preventing bleeding by avoiding deep vessels during ESD. It's useful for performing ESD. Last, I additionally show the see-through effect of RDI at the mucous defect margin after endoscopic resection. It is important to confirm the mucosal defect margin after endoscopy detection in order to reduce local recurrence rate. First, you can see the diurnal EMR. We usually use NBI with closed view to confirm the tumor. However, it is not easy to do that due to bleeding. Earlier can emphasize the visibility of mucosal defect margin after EMR with see-through effect. We can confirm that there is no radial tumor. Right side is post-chronic chordostomy pulvectomy. Immediate bleeding after cold pulvectomy is frequently seen, and so it is also not easy to confirm the presence of radial tumor due to bleeding. RDI can emphasize the visibility of mucosal defect margin after cold pulvectomy with see-through effect. RDE, which ends the summary slide of my lecture. RDA appears to be promising IEE, which enhance the visibilities of cheek blood vessel in deep tissue and bleeding point in GI endoscopy. Bleeding point can be demonstrated with see-through effect and color contrast using RDI. Professor Yahagi stated another benefit of less physiological stress while performing endoscopic hemostasis using RDI. The red color of bleeding imposed added physical stress on the endoscopist, as it puts the endoscopist on alert, much like the red signal of traffic light. In contrast, the color yellow is a feeling of optimized and confidence. So, RDI provides several clinical impact in ESD, poem, bleeding, peptide ulcer, chronic diverticular bleeding, and post-EMR and cold pulvectomy. In my opinion, with the widespread use of full-time RDI in future, it is expected to reduce the frequency of bleeding adverse events and procedure time of ESD, other endoscopic resection and endoscopic bleeding treatment. The available evidence is insufficient to support the use of RDI, so further clinical studies are needed to widespread use of RDI based on EXPAND system. Ladies and gentlemen, this is the final topic of my presentation. This slide shows the preset of the EBS EXPAND for your benefit. We usually use F5 in NBI and Mode 1 in RDI, respectively, in our institution. RD has three observational modes depending on the purpose of use. As shown in this slide, RDI Mode 1 has the function to enhance the visibility of the cheek blood vessel in deep tissue. And enhancement of bleeding point with color contrast also stands out in this mode. So, Mode 1 is suitable for GI bleeding, include intra-procedural bleeding, and identified demarcation line of muscle layer in ESD and poem. The visibility of cheek blood vessel in deep tissue is emphasized in the Mode 2 more than Mode 1. We recommend using this mode for observation deep blood vessel for initial location injection during ESD or poem and predicting the depth of esophageal varices. The future of Mode 3 is to emphasize both thick vessel in deep tissue and relatively thin vessel in the mucosa. This mode is recommended when using for evaluation of ulcerative colitis. Thank you for your kind attention.
Thank you, Professor Yuroka, for that excellent coverage of new technology that is definitely going to revolutionize the way we do therapeutic endoscopy. I have one quick question before we open it up for discussion. That is, what is the learning curve of this technology? How many cases should we do before we become comfortable?
Thank you for good question. Especially, I feel the learning curve is not so required to use this new technology. It is easy to use. This novel imaging endoscopy, especially RDI, may be beneficial for not only expert endoscopists, but physicians who are not necessarily expert in endoscopy procedure. Thank you.
Thank you. Terry, you have anything to ask? Sir?
Yes, of course. It was a great talk. But for me, I want to know when you use LDI, because of course I observe that you can use always during you can use full time during ESD, but is it the reality? Do you use only when it is bleeding? Do you use only when you see a large vessel? Or do you use full time, practically speaking?
Thank you for good question. At the earlier phase, I switched the mode from white light imaging to RDI when occurring bleeding. But recently, I maintained the imaging RDI, this name full-time RDI. It is easy and easier and simpler.
Okay, but the image looks not too artificial. Maybe you miss some of the details because you are using RDI.
Yeah. Yes.
The risk is that maybe you don't see so well the lesion because you are using RDI, or really RDI does not change the quality of imaging.
No. Based on the situation, we can use white light image and NBI. So switching is easier. We can various imaging based on the situation.
Okay, and just last question. Sorry. Okay, you demonstrate that it has a role on the psychology of the operator. Of course, you can easily stop a bleeding, but at the end, the evidence should come from the fact that you reduce the recurrence of bleeding. So, you will conduct a study about recurrence of bleeding, or is it not too difficult?
No difficult.
Yes.
Yes. In the study, yes. Sorry. No. Yes.
Not yet. Huh? Okay. Because the real benefit will be to demonstrate that you have less bleeding recurrence, of course.
Exactly.
But okay, we'll see this in the future.
Thank you.
Maybe Nagi, we can thank you. A great thank you to Toshio for this presentation. Maybe we could begin a larger discussion with both experts. Nagi, you want to begin the discussion?
We'll go to the general discussion, but this is a very important point that Terry has made. How do you actually demonstrate the efficacy of this new technology, both diagnostic and therapeutic? And let me come to therapeutic because we have some experience with RDI. It is very difficult to demonstrate the outcome in terms of reduced rebleed because in an expert endoscopy center is not going to change so much. What we have evaluated is the reduced hemostasis time. How much time it takes to stop the bleed of white light versus RDI. And we found something very interesting. We actually did about 31 poems using this. And what we found for expert endoscopists, it doesn't make a difference whether they use RDI or white light in the hemostasis time. But for a novice, a person who's starting poem, for example, it makes a lot of difference. His hemostasis time is much smaller compared to when he does with white light. And we found that people are getting comfortable by about 5 procedures. So a learning curve is really about 5, I thought. And we found that for a novice endoscopist, if he uses this technology, then his bleeding or hemostasis time comes down. So I think, Terry, the outcome study should be done in form of the bleeding time, the hemostasis time, rather than rebleeding.
Okay.
Because otherwise, it will require a large number of cases to show a difference.
I agree with you. Okay, it is too demanding to ask for an evaluation of bleeding recurrence. I agree. I think, okay, to measure the time, or maybe to measure the number of blood units you need could be sufficient. Now we can, concerning I want to discuss with Dr. Abe and of course Uraka also could interfere about TXCI, and because the problem we have now is that Olympus is providing so many functions and so many new functions, and we already have structural enhancement, we have NBI, etc. And now we have RDI, of course, but with TXCI, magnification, etc. And so I don't want to say I'm lost, but there is a challenge, too many tools to evaluate. So first impression concerning TXCI versus NBI in general, because I was very happy with NBI. Now I'm okay. Why not to work with TXCI? But you have to show me that it is more effective than NBI. So TXCI versus NBI in the stomach and in the colon, please.
In the stomach, I was so surprised at the image quality of both TXI and NBI. As I told you in my presentation, the visibility of the early gastric cancer could be improved by TXI, of course. But the image quality of NBI is also improved in EBIS X1 system. So maybe the visibility of the early gastric cancer can be improved by the NBI as well. So I think the large comparative study is required to evaluate the early gastric cancer detection rate in current image enhanced endoscopy. So I think the randomized control trial is warranted.
Okay, so you mean detection? You mean you enter into the stomach and you use white light versus TXCI or versus NBI? Okay,
yeah, so currently we have the three mode, white light, and NBI and TXI.
Okay, okay, and now the colon. The colon.
Yes, colon. Yes. This is a very difficult question, but I like NBI than TXI. And the image quality of NBI has been also improved on a new system, EBIS X1. So we can see the bright and beautiful image of NBI on the new system. So I expected achieve more detection of corrected polyp using new NBI. But I know the benefit of TXI. So the comparative study between TXI and the new NBI image are needed for polyp detection. Thank you.
Okay, it's quite clear. And concerning characterization of polyps, you see TXI better than NBI, or same or worse?
Thank you. A good question. For the characterization of the corrected polyp, NB is much better than TXI.
Okay.
We achieve a clear image, especially of NBI with magnification.
Okay, and then, I don't want to maybe Nagi, you can interfere, but concerning now magnification, I was impressed by the magnification. And especially if magnification is quite easy to use. Okay. So do you see now a role of systematic magnification in case of characterization and to look for vascular network, especially Dr. Abe in the stomach?
Yes, for the region characterization, I routinely use the NBI magnification, and the image quality of the NBI magnification in EBIS X1 is also great.
Yeah. I was impressed. Yes, because I have a feeling that the previous generation, we did not analyze so easily the vascular pattern. We were more impressed by mucosal pattern. But now maybe with the magnification, we will be able to really analyze accurately the vascular pattern. And same in the colon, Uroka?
Yes, this is the same situation. Yes, I agree.
Yes.
Yes.
Nagi?
Yeah, so I think, Terry, you'll agree with me that with the current standard endoscopes that we have already, the bar is very high. It is going to be extremely difficult to demonstrate that these scopes, how much more better they are. Because, for example, polyp characterization with the standard high definition white light and NBI, we can almost characterize the whole polyp, and especially because we're seeing the vascular pattern so well. So it's going to be difficult. But when this new scope was first introduced and Olympus actually got it to us, and I started holding it and seeing, I said, wow, this is a new standard that they're setting, much above what happens originally. So even though it's going to be difficult to demonstrate from studies, randomized controlled studies, the efficacy in terms of both diagnosis and therapies, I think one can be sure that this is going to be the new standard for us. So Abe and Uroka, what do you think about the new functions, and how are they going to become the standard now? Is everybody going to demand that they should have these functions in their endoscopes?
Yeah, I expect. Thank you for the question. I expect the new imaging RDI will become to be standard mode when, especially in the bleeding situation. I hope so. I expect that.
Okay. Thank you very much. I have a special request finally for Olympus. Because we have so many new functions, why not to use artificial intelligence to tell me, okay, for this case, this is you should use this, or the settings is automatically upgraded for me. To use artificial intelligence to select the best function adapted to this lesion or to this organ. This is basic, but could be very helpful, because now we are facing the problem that it's probably difficult. We will have our own settings. We got fantastic feeling with this technology, but maybe the risk is to be lost a little. What do you think, Abe?
Yes. So as I told you in my presentations, new image-enhanced endoscopy can be utilized for new artificial intelligence, because image quality is better, and also the distal side can be illuminated, so that I think that we'll be able to obtain the better image data set for AI.
Exactly. Using AI, we get the better setting. And
I think so.
Okay. Uroka, the same opinion?
Yes, various AI software has been will be sold from Olympus in the future.
Yes, okay.
This is a very interesting point that you made, that all the time we're talking about artificial intelligence in endoscopy to better enhance lesions and tell us whether it's malignancy or not, and so on. But here, I think Terry is talking about another dimension of artificial intelligence, where the machine settings are set by artificial intelligence, so that we as endoscopists don't have to remember is it going to be V6 or V7 and so on. So it automatically comes in. That's a very interesting concept. I think Olympus should take it up and think about it, so that some of us, at least the older generation, doesn't have to go through all these different settings, and automatically the settings come into place. That's a nice suggestion. Yeah.
Okay, so maybe Nagi, you can conclude. We had a great presentation thanks to our two colleagues, and I want also to thank Olympus.
Yeah. So you'll all agree with me that we've had a fantastic evening symposium, and I'd like to thank, on behalf of me and my co-chair Terry Ponson, I'd like to thank Abe and Uroka for these excellent talks. We've had a beautiful videos demonstration of the utility of this new modality of both diagnostic and therapeutic EVS X1 scopes, and I think they are going to be the new standard for us in the future. I'd like to thank Olympus for setting up this symposium, and it's going to be an extremely fruitful symposium for all the audience who've been involved in this. And I think we're going to revolutionize both the diagnosis and therapy of many GI disorders with these new modalities, and hopefully this is something that's going to help all of us in better patient care. Thank you very much.
Thank you.